much for joining us. You are with us here live for the second day of the live interview sessions as part of the 22nd Bangkok International Symposium on HIV medicine, where the latest advances in HIV are shared. Delighted to have you with us, and delighted to have with us as well Dr. Siwaporn Ket Jumpon, who is with HIV-NAT, the Thai Red Cross AIDS Research Center. Sawadee ka. Thank you for coming in here, and you will be extracting the information and further details from our guests, three together, and we will be focusing on tuberculosis TB as well as hepatitis B cure as well. So bringing on our first guest now, we have Dr. Frank Cobelens, who joins us from the Amsterdam Institute of Global Health and Development. Sawadee ka. Welcome back.
Thank you.
How many times is it now that you've been here?
I think it's the third.
Is it? Is it? So same as well. So 3 consecutive years, and very good to have you come and give us the latest in terms of TB, the development so far after 1 year. So over to Dr. Siwaporn.
So just Frank just give us a talk about a TB diagnosis, and I would like to ask you a comment on what is really need for TB diagnosis. What is the gap?
I think that, we've done, I think, pretty good over the past decade in terms of developing new diagnostics. For example, in the molecular diagnostics, sputum diagnostics. I think one thing that is really missing is something that will allow you to tell really at the first contact between patient and doctor whether tuberculosis should be a serious consideration in a differential diagnosis. So it basically tests, it's a very simple test that can rule out that this particular patient has tuberculosis would be very important, because if such a simple test turns positive, you would say, okay, you'd better be checked for tuberculosis. Patient could then be referred for further testing, because I think in practice, patients have journeys of weeks to months during which they have tuberculosis and symptoms related to tuberculosis, whereas that is not recognized clinically, and the appropriate tests, even though they're there and they're very good, are not done.
Yeah, and during that time they can transmit the disease. Yeah.
Absolutely. I think that currently epidemiological studies are indicating more and more that already in very early stages of tuberculosis, even when the symptoms are not very clear and very easily recognized by a clinician, that during that period patients already transmit.
Yeah, and what do you think is the best logarithm for screen TB in setting of result limited settings, such as in Thailand and Southeast Asia?
I think the best would be at the very first contact at the health post or at the by a community physician, to already have indeed. Currently we don't have such a test. That's the problem, and I think there's a lot of work ongoing in order to get such a test, and I think there is hope that we will have a good, what I call triage test, which will indeed allow you to rule out that the patient has tuberculosis at the very first contact with the doctor. But we don't have it yet. Once we have it, that would obviously be the first thing to do, and then have gene expert or any other molecular test that is available in the second stage.
Yeah, and now that we have increased the number of molecular testing for TB, do you think this will be insist the very standard testing such as AFB, SAN? The molecular testing will be replace the AFB?
I think it definitely will, and I think it should. We know that AFB, so smear microscopy, has a low sensitivity. It's a pretty cumbersome test. So and we know that the molecular tests are affordable, and I think they should really replace smear microscopy. Another reason is that most of these molecular tests also test for rifampin resistance.
Yes.
So they give you an immediate result as to whether the patient potentially has multi-drug resistant tuberculosis. So that really means that you need to do a different diagnostic workup and give different treatment.
And what do you think is the need of the need of the research? What is the topic of the research that's needed to find a new diagnosis?
I think there are two things really needed here. I think there is discovery and needed for new diagnostics. So there is really more basic research needed. There is more research needed to translate those discoveries into new tests. But I think very importantly, also here in Thailand, there is real need for implementation research. You real need to see how new tools, whether it be diagnostics or drugs or other things, can be best used in clinical practice. I think that's tremendously useful, also to see how they can reduce transmission and improve survival of patients.
Okay, I think
All right. Thank you very much for your time, Dr. Frank Cobelens, once again, and we do hope to see you next year, and we do hope to see more developments. Yes.
TB diagnosis.
That's right. Once again, we thank you. ขอบคุณค่ะ Dr. Frank Cobelens, the director of the Amsterdam Institute of Global Health and Development from the Netherlands, talking about tuberculosis diagnosis, biomarkers, and unfortunately we didn't have as much time as we wanted to because we were a little bit delayed from the conference rooms, but we will now go into finding out the latest, getting an update on TB treatment as well as the challenges. Joining us, we have Dr. Richard Chaisson, the director of the Johns Hopkins University Center for Tuberculosis Research. สวัสดีค่ะ Thank you for joining us.
Thank you. Delighted to be here.
Yeah, this is the first time for Dr. Chaisson to join our conference. This is a pleasure for our conference to have you here.
Definitely. Great to have you here. So let's talk about the latest updates when it comes to treating tuberculosis.
Yeah, but because nowadays we use integrase inhibitor, and in the near future, the integrase inhibitor will be the first line of ART regimen in many countries. And today we know about the drug interaction, about the dolutegravir and raltegravir with the anti-TB drug. But what is about another integrase, such as a bictegravir? Do you have any data on that?
Yes, the company that makes bictegravir, Gilead, did a study looking at the interaction with rifampin, and what they found was that there was a reduction in the bictegravir levels to a point that concerned them, and so they, as the manufacturer in the Food and Drug Administration, don't recommend giving bictegravir with rifampin. I think that it's very likely, though, that the bictegravir and rifampin interaction could be manageable, and so they did not look at viral suppression. They only looked at concentrations in the blood. So for now, bictegravir shouldn't be used with rifampin, but perhaps in the future there will be some more studies to show that it might be safe.
And for the previous study, we know that dolutegravir we have to use twice daily when we combine with rifampin, but they also have a data that we can increase the dolutegravir level by eat with food or high fat meal, something like that. You think it can be like use one daily and eat meal when you eat rifampin?
Yes, with dolutegravir, the pharmacokinetics of the drug are such that it's best given in 50 milligram doses twice a day with rifampin. But there has been some research looking at giving it once a day as a single 100 milligram dose. And even though you don't get the same exposure that you get by giving it twice a day, it makes it so much easier for the patient,
Yes.
And so much less likely that you will have a missed dose and non-adherence. And so I think the results of the study of once daily dosing and doing things like you suggest with increasing absorption make a lot of sense. And so I think we'll see a study in patients now with active TB where that approach is used.
Okay, and we'll move to the latent TB treatment that you just talked. And do you think what is the most challenges or barrier for implement the latent TB treatment?
I think the biggest challenge for preventing TB is that many people, including doctors, nurses, and patients, just don't feel that it's a high priority. They don't appreciate the fact that a third of all deaths in people with HIV are from tuberculosis. And it just hasn't been a priority. Getting antiretroviral therapy has been a priority. Of course, we should, but we now know that we can add preventive therapy and reduce deaths by another 40%. If we had a new HIV drug that reduced death by 40% in addition to ART, everyone in the world would want it. We do have a drug. It's a preventive therapy, and it reduces deaths by 40%. So that's the biggest challenge, that people just don't feel that it's important.
Okay, so I think we run out of time.
Right, thank you very much.
Thank
Actually,
you.
It's a topic quite close to my heart because my husband contracted TB.
Ah.
Yeah, so we know, I mean, but before that, I was thinking like, TB, this can't be possible. We're living in these modern ages whereby, and I think that's some misperceptions. I think education is so extremely important for the general public because they don't understand the severity of it, how easy it is to spread sometimes, and etc. So I think that's also so important, and I'm very pleased to see that the Thai government is doing more now because I see posters, signboards saying that we do want to bring tuberculosis down to zero. But thank you very much. Appreciate your presence here with us.
Thank you.
Thank you, Dr. Richard
Thank you.
Chaisson, the director of the Johns Hopkins University Center for Tuberculosis Research. Next, we're going to move on to hepatitis B cure. Dr. Sharon Lewin, she was here last year, and she joins us once again. A warm welcome to Dr. Sharon Lewin from the Doherty Institute for Infection and Immunity, University of Melbourne, Australia. Hello, Swadika. Welcome back.
Pleasure to be here.
Okay, let's now focus on this topic of hepatitis B cures.
Yeah, in your lecture, you just talked that many mechanisms of drug that can be combined in order to cure the hepatitis B. So in case of hepatitis B mono-infection, do we have to wait to the immune reactivation phase to treat them, or just treat them when you found that they have a chronic Hep B infection?
Well, in hepatitis B monoinfection, the current guidelines recommend only treating in that immunoactive phase, meaning someone with evidence of abnormal liver function. And that's where current treatment, and we have very effective current treatment for hepatitis B, except it's lifelong. That's who will benefit from treatment. The concept of whether cure should be available to everyone living with hepatitis B is probably a bit more controversial, but certainly people that need lifelong antiviral therapy would get great benefit from having to be on treatment for 1 to 2 years rather than forever. And that's the main priority for working out if you can cure people on current antiviral treatment.
Okay, and recently we have an injectable drug for HIV, such as a long-acting cabotegravir or rilpivirine. Do we have a new injectable drug for hepatitis B?
Some of the compounds I discussed were injectable drugs, but I think what the breakthrough with injectable drugs in HIV is that they're long-acting, and they're long-acting reverse transcriptase inhibitors that we heard yesterday, the Merck translocation inhibitor. I am not aware of similar programs in hepatitis B, but you technically could do the same thing because Hep B has lifelong suppression with drugs that we use for HIV. They block reverse transcriptase. So if you could deliver those drugs in an implant or injectable, you could do exactly the same thing in hepatitis B. I don't know of any companies that are doing that.
Okay. And do you think what is the most challenges or barrier in hepatitis B cure?
Compared to HIV cure. Oh, so I mainly work in HIV cure. I've always been interested in HIV, hepatitis B co-infection, but I work with many colleagues in my institute in Melbourne who work on hepatitis B cure. So I follow the field with great interest. I think curing hepatitis B will be much easier than curing HIV. And the reason is that people already are cured from hepatitis B. It happens in 5% of people on treatment, and 80% of adults can eliminate hepatitis B. We just don't have, in HIV, we have 2 people in the world that are cured. Yeah. So I think the absence of a biomarker, the absence of evidence in natural history of functional cure makes HIV much harder. Yes. And what I wanted to convey in the talk was if you have those things, a biomarker for cure and evidence that cure is possible in a significant number of people, industry will join the challenge. And I showed a slide with probably 40 compounds on it that are being developed in the private sector, and we don't have anything at that level in HIV. A few companies, of course, are interested in HIV cure, Gilead and Merck and ViiV, and Johnson & Johnson and others, but their investment's still at a low level because it's a high-risk area because of a high chance of failure. Hepatitis B is in another phase. So I'm very jealous about what's happening in hepatitis B.
Yeah, and just curious about the vaccine that is now available for prevent hepatitis B. Is it enough?
Well, a vaccine is absolutely critical to prevent new infections, and there are many countries in Asia Pacific who do not have adequate coverage of vaccine or burst dose vaccine or administering antivirals to Hep B positive mothers. So that still there is room for improvement. But even if you could effectively deliver all of that tomorrow, you do still have 350 million people living with hepatitis B. A large number of them, maybe 25 to 50%, need treatment. So we have a very large cohort of people that will need lifelong treatment, a little similar to HIV.
Yeah, and because of our patients have a lot of, after they have vaccines, but they didn't have immune or the anti.
Right, yeah.
Yes. And do you think what is the cause of the
non-response?
Non-response.
Yeah. Well, there is a subset of people who do not respond to hepatitis B. It's more common in HIV. If you vaccinate people, once people with HIV are on antiviral therapy and their CD4 count's greater than 200, they begin to behave similarly to people without HIV. There's new developments in vaccine regimens that can improve the response of non-responders, but there will always be a percentage of people that don't respond to HIV, to the vaccine. But in measles, for example, or in areas where we have very effective vaccines, to reduce population prevalence, you may not need 100% uptake or 100% efficacy. So I think non-response to the Hep B vaccine is an issue for the individual. I don't think it's a big issue at a population level, given its frequency is around 10%. So the vaccine's 90% effective.
Okay.
Appreciate your presence, Dr. Sharon. Thank you so much once again, and we hope to see you back next year as well.
Thank you.
ขอบคุณค่ะ And we were just speaking here about hepatitis B cure to Dr. Sharon Lewin, who joins us from Doherty Institute for Infection and Immunity at the University of Melbourne, Australia. And that is going to wrap up the first live interviews for today. Join us again at 12:40. We have more coming your way, and don't leave us just yet now, because we will be taking you back inside the conference rooms to listen in on the gurus and experts, give you the latest on HIV treatment. And that's it from me for now. I'm Pacharia Raksawong. Sawadee ka.